Hi, I'm Dale Sherbeck, and welcome to the HQ, a CHA Learning and Healthcare Can podcast serial where we dive into healthcare issues and topics from the perspective of its people and discuss them with those that are leading in the health system. Together, we'll try to unpack these topics and learn what actions are being taken to innovatively solve them today. Last week, the country's highest political leaders descended on Ottawa for a much-anticipated meeting on healthcare, one which was long called for by exasperated patients and exhausted healthcare workers across the country. Prime Minister Justin Trudeau and supporting federal ministers spent the days leading up to the meeting working to tamp down expectations. The provincial and territorial premiers spent the same period making it clear their expectations were high. And the media worked both sides to keep everyone at a fever pitch as to whether or not February the 8th would be the latest and greatest healthcare fix for a generation. The real question being asked by everyone of everyone is whether they delivered. To discuss all of this and more, I'm thrilled to be joined today by Dr. Michael Gardam, Chair of Healthcare Can Board of Directors, CEO of Health PI in Prince Edward Island, and a veteran of healthcare systems in 3 Canadian provinces over 3 decades, who has made it clear in his comments that the political brinkmanship approaching to solving Canada's healthcare woes is exactly the wrong approach. In the media coverage before and since, Michael is well quoted as saying, "No more backroom bickering and no more sacred cows." Instead, he says it's time for a real and open dialogue across the country on the outcomes and services Canadians expect their healthcare system to deliver and what it cannot. Then, and only then, he contends, can the work truly begin on building a system able to respond to the needs of Canadians now and into the future. For those of you listening who don't know Dr. Michael Gardam, he is a pioneer in complexity science-based approaches, including positive deviance and frontline ownership, to improve patient safety and other complex challenges. Dr. Gardam is an associate professor of medicine at the University of Toronto and has published more than 120 scientific works. He holds master's degrees from McGill University and the University of Toronto and is a fellow of the Royal College of Physicians and Surgeons of Canada in infectious diseases. His interest in physician leadership and organizational culture led him to become chair of the Medical Advisory Committee at UHN in 2015 and chief of staff at Humber River Hospital in Toronto in 2018. He is currently program director of the York University Schulich School of Business Healthcare Leadership Development Program and an instructor for the Physician Leadership Institute of Joule. Dr. Gardam has also advised many organizations in Canada and internationally. Some of these have included the World Health Organization, the Centers for Disease Control and Prevention, Excelis Blue Cross Blue Shield, Hand Hygiene New Zealand, the Irish Health Services Executive, the Maryland Patient Safety Centre, the Canadian Foundation for Health Improvement, as well as numerous other hospitals across Canada. Hi, Michael, and welcome to the HQ.
Hi, thanks for having me.
It's truly a great pleasure to have you join us here today, Michael. I know you have many fans and admirers in the system, and I expect after our conversation today, you may have a few more. So maybe we can just jump right into things then, Michael. As anyone in the system knows, and all our politicians know, and as many Canadians who listen to and read to the media know, our system or our systems are in crisis. Prime Minister Trudeau said as much as part of his announcement at the First Ministers' meeting on February the 7th. So would you agree with that? And if so, how would you describe the current state of healthcare in Canada?
Yeah, I would definitely agree that we're in a crisis. I think the really key point there is that we're actually getting a growing number of politicians and Canadians openly acknowledging that. And it wasn't that long ago, maybe only just before the pandemic, that we were still repeating the line that we have the best healthcare system in the world. And where it was common for anybody who made any challenges against Canadian healthcare would immediately be hit with, but we have the best healthcare system in the world. And, it wasn't that long ago that CBC, the Globe and Mail had done polls on like, what's the most important thing in Canada? And it's, Tommy Douglas and it's healthcare.
Yeah.
So, I like to say that the first step towards getting better is admitting you have a problem. And I think Canada has admitted we've had a problem.
Yeah.
We're in crisis, a serious crisis right now, because we were already in bad shape. And then the pandemic has just decimated what was left. It's hard for Canadians outside of healthcare to understand how hard the pandemic has been for healthcare. The first half of it, we were terrorized that we were going to catch this and get sick and potentially die, like the person that we're caring for right there in the hospital.
Mm-hmm.
That started to calm down a bit once we got vaccines and once we had treatments and things. COVID became less scary, but by that point we were fried. People were exhausted. They're doing more overtime than ever, et cetera. So we face an extraordinary health human resources crisis now in our system that we have never experienced anything like that before. And so, you add that on top of the fact that even before the pandemic, when you look at different rankings from things like the OECD looking at comparing Canadian healthcare to other developed countries around the world, we don't look very good. We always usually look better than the US, which makes us feel good. But there's a lot of other countries out there that do far better than the US. And I think it's our natural Canadian tendency to compare ourselves to the Americans, which has missed out on the reality that pretty much everybody else in Europe has a better system. And by better, I mean they have more hospital beds per capita, but typically their systems are still cheaper.
Mm-hmm.
They have a lot of better outcomes in terms of patients than we have. And, just on the hospital bed thing alone, the NHS is in extraordinary crisis right now in the UK because they don't have enough hospital beds. Well, guess who's tied for them at the bottom of the list? Canada. We also have the same number or the fewest number of hospital beds per capita of any other developed country, except we're tied with the UK. And we've let our system get this way over the last few decades. And then the pandemic has literally been, the final kick. And here we are today. So when people use the word crisis, it is definitely a crisis. I feel it every single day in our healthcare system here on the island.
So, building on that, so as you're saying it, so COVID didn't start this. It's exacerbated something that was already happening. It's focused our attention on something that we, I guess, were, somewhat blind to, at least outside of those who worked in healthcare before this. But in your view, how did we get here? If it wasn't the pandemic that has fueled this, where did this start? How did it start? And what are the issues that continue to perpetuate this?
Yeah, I'll be the first to say that we're not getting a good return on our investments. We are not the most expensive healthcare system. I guess my first point should be we don't have a Canadian healthcare system. We have 13 Canadian healthcare systems, and that's part of our problem.
Mm-hmm.
But we don't have the greatest return on investment. So we tend to be relatively expensive for what we get. And in terms of, how we got there, there's no one reason. I think, the first reason I'll talk about is that there's probably nothing more political in Canada than healthcare.
Mm-hmm.
And so if you hold up the Canadian healthcare is sacred and you're not allowed to challenge it, and it's highly political, then if there's any government that does want to try to get in there and really start to make some significant changes, they are going to be attacked from all sides. And, imagine if you're a company where you're not allowed to innovate and change your key product. Nope, got to leave it the way it is. And if somebody says they want to have a virtual keyboard instead of a solid keyboard, the entire world attacks them and they back off.
Mm-hmm.
Right? So you're not allowed to innovate in Canadian healthcare because you're not allowed to fail, because if you fail, it'll become a political hot potato and everybody's going to be upset. As opposed to saying, you know what, we tried it, it didn't work, we're going to back up, we're going to try something else. So to me, the politics are central to Canada's problem. I'd also say that the endless finger pointing between the provinces and the federal government has just left everybody saying it's somebody else's problem. And that has gotten us nowhere, right? Both levels of government have an important role to play in Canadian healthcare, right? The federal government has set the guiding principles through the Canada Health Act, and they do provide funding to the provinces. But the provinces are crystal clear that they own the delivery of healthcare services. They will fight to the death on insisting that they own the delivery of healthcare services. So then why, when they talk about innovation, is it always looking back at the federal government saying, give us more money? The provinces have to own a piece of this, a very large piece of this. The feds own a piece, the provinces own a piece. And until we stop the endless back and forth bickering and finger pointing, we're getting nowhere. And in the meantime, the Canadian system just gets worse and worse and worse. Like, at what point do we have to hit the crisis where Canadian public opinion is so great that all levels of government realize, okay, we have to stop what we're doing. We're going to have to take a different tact here because this is clearly getting everybody upset. I give the example of medical assistance in dying, right? Government was very against that until it became very clear that there was clear majority public support for Canada getting into that area of MAID. So in that case, the population influenced government, the population led government to get there. I hope we're going to do the same thing with Canadian healthcare, where it becomes so clear that doing the same old finger pointing is not going to get you reelected. You actually you're going to have to do the hard stuff. So, I think that's part of it. I think another part of it is measurement. And do we actually evaluate what we're doing and back away from things that aren't giving us a good return on investment and doubling down on things that are clearly giving us a good return on investment? We don't have great Canadian data because, again, it's a provincial responsibility. Kai collects what it is able to collect from a national perspective. But because we got 13 different healthcare systems, it's never as complete a data set as you would like it to be. And then what I've often said here, and I think it's particularly true for us in the Maritimes, the politics, the smaller your province, the closer the politics are, right? And so, healthcare systems in Atlantic Canada are very closely tied to politics. And, we'll often make choices on what program to deliver or how to deliver it based on political nudging in that direction, not necessarily based on evidence, not necessarily based on data, but rather based on different constituencies. And that's a lot of money we're playing around with. And like one of the messages I've been giving here on the island is that I am in charge of healthcare for the island. I'm not in charge of healthcare for one riding. I have to do sort of the Canadian approach, which is I have to do as much good for as many people as I possibly can. And so the politics can get in the way of that. The last thing I'll say, I think, is that because it's sacred and because we're not able to have these hard conversations, I feel like we add stuff to Canadian socialized medicine kind of willy-nilly, in that we're not really sitting down and having the hard conversations around what do we want to fund and what do we not want to fund. An example came up yesterday where somebody was asking me, these standalone ophthalmology clinics, is it fair for them to so-called upsell clients to say, get a better lens? So the standard Medicare funded lens is great, but if you want a lens that gives you bifocal capabilities and stuff, you have to pay more. And the question was, well, shouldn't we be funding that? Shouldn't we be funding the best lens? And my question was, I don't know, should we? That's going to cost money. What are you taking that money away from somewhere else? Because we don't have unlimited funds. And so is, a solid minimum service what we should really be focusing for? And then stuff that's more elite, higher level like stuff, do we have debates about what we're going to bring on, what we're not going to bring on? If you've got a clinic that's 45 minutes from your house, but you want a clinic 15 minutes from your house, is that something we should invest in? Or do we accept 45 minutes is not bad? We don't have those conversations. And so that's why one of the premiers at the meeting this week said, whatever amount of money the feds give us, we can spend. So you want to give us $500 billion, we could probably spend that in the blink of an eye. the bigger question is should we be doing that? And so, I guess my overall plea is we need to cut with the politics, and we need to have open, honest conversations where we challenge each other about what we want Canadian healthcare to be. Because I don't believe we've ever really done that. We've just sort of perpetuated the model that was set up over half a century ago.
Yeah. And that makes sense to me, Michael. I mean, from my own, vantage point of, doing learning and development, right? We start with an outcome, right? We figure out what it is that we want people to achieve, and then we build a course or, right, learning that helps you to achieve that. And right, so I think the questions as you're raising, right, is do we actually have a vision for what we want our Canadian health system to be, how good, how state of the art it should be, what it should deliver, and then resource it appropriately. A couple of things I think that you've described in that, though, is like, so the 13 jurisdictions, right? Right, the kind of the sacred cows, right, that we have in all of that, whether it's an image of Tommy Douglas on our Canadian flag instead of a maple leaf, right? That we get mired in, I think, as you're saying, this finger pointing, which is, I guess, in some ways, an avoidance of responsibility or accountability in
Yeah.
this. So is the, like, I don't want to sort of make this into a discussion about the Canada Health Act, right? But is the question about our jurisdictional approach? Is it, you're even talking about the measurement part of it and evaluation, but that's happening within jurisdictions or within organizations. So is it the national part of this that we're not doing, or is there something else in that you would sort of see?
Yeah, I think it's, there are components of the Canada Health Act that I think if we were to, break it down for people and ask, what do they feel about this? I think, there's large parts of the Canada Health Act that I think Canadians would readily agree on, right? Is healthcare, our healthcare service is universal. Like, if you're a resident, can you get healthcare?
Mm-hmm.
I don't think there'd be a lot of people saying no. We need to make it hard to join the insurance plan, right? I don't think people would argue with that. Similarly, I currently have health PEI coverage, but if I go back home to Ontario, I want to think that if I break my leg, they're not going to say, sorry, you don't belong to our plan, right? So the Canada Health Act says it has to be transferable.
Mm-hmm.
I think the part of the Canada Health Act that people get caught up in is the whole private versus public issue. And I always feel I have to remind people that the relative percentage of Canadian healthcare that's delivered privately is roughly the same as the United States.
Mm-hmm.
All of our fee-for-service doctors are private contractors. Any physio clinic you go to, any optometrist you go to, I have drug coverage for things like dental care and medications and all these other things. None of those things are covered under our insurance plan. They're covered under other insurance plans, or you pay for them out of pocket. So the idea that we're going to privatize Canadian healthcare, we've never stopped privatizing Canadian healthcare. It's always been part of our system. The question is which parts.
Yeah.
So most developed countries, for example, have national pharmacare programs, and drugs are one of the leading causes of increasing costs in Canadian healthcare. They just keep going up constantly. Every time I look at the formulary, there's another 50 drugs that I've never even heard of. They didn't exist when I went to medical school.
Mm-hmm.
So most developed countries have said, we really need to fund that. Okay, then what are we not going to fund? Right? Like, what are we going to take away? Because we can't just keep adding. And so if a majority of Canadians say that national pharmacare is clearly something which is very important to them, okay, that's something it sounds like we should probably have. I would think most Canadians are going to say, if I have an emergency, I want to have access to emergency care. No doubt about it. I don't want to die because I can't get to a hospital. And I think you've heard loud and clear, Canadians want access to primary care. Mm-hmm. Now, I don't think Canadians need access to, everyone needs a family doctor. I think they need access to primary care, which is, we're moving towards family health teams and the idea of a group, multidisciplinary practice. I think Canadians would agree with that. But then you get into, should all Canadians get the fancy lens? We hear nothing we hear constant stuff about the wait times for knees and hips. Okay, are those more important to Canadians than getting abdominal surgery for cancer? I don't know. One of the reasons we focus on cataracts and knees and hips is because that's something which is easily defined and measurable, and we have good Canadian data on it.
Mm-hmm.
But then we're changing our healthcare system based on what we can measure, not necessarily on what the really important things are. And those are those fundamental conversations that we need to have, with the hope that it'll get us to a Canadian healthcare 2.0. But I can tell you, in my role as CEO here, there is a nonstop conveyor belt of demands for adding more and more services. And there's no way this province can possibly afford all of those services. And we have to figure out what's in, what's out. And I just feel like we're still behaving like we're back in 1960, where hospital care was cheap. There weren't very many drugs, and you were just paying doctor's fees. And, there were no MRIs, there were no CT scanners, there was no such thing as an ICU, there was no such thing as colonoscopy, there was no such thing as sort of personalized medicine for cancer care. None of that existed. So, the foundations that our system are built on things that are so different from today.
Mm-hmm.
So that's why and I'm also the first one to say, I have no clue how to fix our system, but I do know if we have these conversations, we can get there.
Yeah. But the conversation's about choices fundamentally,
Yes,
right?
It very much is about choice and what matters the most.
Yeah. So, I think a lot of that, as you describe, is going to come down to Canadians themselves in terms of the pressure they put on and the voice that they express to our political leaders. How do you think, I guess, in terms of that voice, how is the system serving them right now? Right? I guess we hear a lot, obviously in our field, we hear a lot about healthcare leaders in terms of what they think. We're hearing what politicians are thinking, but what do Canadians think right now in terms of the system or systems?
I think that's a great question. And I don't think that I think we need to have national dialogues about this, and they're not currently set up. But I would also argue, at the same time you're having a national dialogue, you got to have a provincial dialogue. And that really fits with my experience here, right? We're the smallest province in Canada. We have a small population. I cannot provide every healthcare service that islanders want. We're just too small, right? I don't have neurosurgeons on the island, or thoracic surgeons, or vascular surgeons. I don't have cardiac surgeons. And I could never support that because our population is just too small. So Prince Edward Island needs to have provincial dialogues on what do islanders really need and what do we have to send you away for, right? So right now you have a heart attack on the island, we'll start your treatment here, but chances are you're ending up in New Brunswick. And once in a while there's calls for why can't we do that on the island? And that's where I'm we need to have those dialogues to figure out, well, if you want that, this is what it's going to take. You're probably going to have to cut into this over here because we won't be able to afford everything. And so I call on, governments across Canada to really start those dialogues. I'm fortunate in my own province because you may have heard my premier speaking that in addition to saying, money's good and we always like more money, he also said, and we have to reform our system. Mm-hmm. And that it's that second part of that sentence, which is really key. Do we get our provinces to acknowledge that we have to reform our systems and we have to quit looking for quick fixes, right? We've had a lot of political quick fixes over the last year or so. I think of some of my colleagues in other provinces, there was something bad happens in an emergency room and the CEO is fired. Mm-hmm. That's a very politically expedient thing to do. That CEO, unless the CEO drove in and, harmed the patient themselves, they had nothing to do with that. And we need to stop that kind of thing and really roll up our sleeves and get into the meat of it. But that's frankly terrifying. It's like, oh my God, how are we going to get through that? And I would argue we have no choice. We've reached the point where we have no choice.
Yeah, I mean, I mean, those are some of the things I guess that we're hearing more and more about, right? Which is these events, right? These moments of harm, and then the desire for, accountability of putting someone's head on a pike, pretty much, right? And
Well,
um, where really, I think in many cases, I guess it's the system, right, that is failing people and those who work in healthcare. Um, how do we change that dialogue, I guess, and sort of really start talking about that part of the,
yeah,
it is a system issue. It's not, it's not necessarily even a money issue.
yeah. You bring up a really valid point. I'm really glad that you pointed that out because, one of the things that I get feedback on is when I talk about our system, some of our healthcare workers are offended because they're like, well, we're trying our best. And to me, it's obvious my comments are not aimed at healthcare workers. Never in a second would I say our healthcare workers are lazy or our politicians are lazy or anything like that. It's that the work we're asking you to do may not be the right work, right? We may need to be doing other things. We may need to be thinking in other ways. And so I think the way you get there is everybody acknowledging that our system isn't working for Canadians and kind of leaving the blame at the door. If there was one guiding principle, it would be you have to leave the blame at the door.
Mm-hmm.
Because that's what we've relied on to get through until now, right? It's basically the analogy I gave is, we slap a bit more money on it, we keep the car driving for another couple of years, and we'll worry about it in like 2024. But the blame thing just kind of allows us to circle the drain for a little bit longer because then people can focus on somebody else. But we have to put the blame at the door and start having the hard conversations about what matters to Canadians. And I don't think it'll be that hard to figure it out, right? We and I also believe, in addition with leaving the blame at the door, I think we need to leave a bit of the provincial egos at the door. So does every Canadian province need to do transplant?
Mm-hmm.
Does every Canadian province, need to do those really expensive high-end treatments like bone marrow transplants?
Mm-hmm.
Um, or do we have defined centers in different regions of the country and we simply acknowledge, you know what, PEI is never going to do a heart transplant, so we need to have a relationship. I mean, one of the things about taking this job, moving from Toronto to here, is that it's made these things so crystal clear for me.
Mm-hmm.
And I don't think I would have had quite the same vision if I would have stayed at UHN, where I had access to everything at my fingertips. Right here, there's all sorts of things I don't have access to. And so I have to rely on partnerships.
Yeah.
And so, we used to talk about it in, downtown Toronto, the competition between the U of T teaching hospitals. And I think that's gotten much better over the last several years. I think the pandemic has helped that enormously as they start to think more of as a group. But the competition between provinces for specialty services and things like that, again, isn't helpful. We don't all need one, and you don't want to dabble in something. You want to go to a place that does a lot of something, and we just need those partnerships. Our system, of course, is designed not to make partnerships. It's designed to have every province stand on its own. And that's, if you could go back to 1867 and change the BNA Act to make healthcare a federal responsibility, some of the structural issues we deal with wouldn't be here today.
Yeah. So you would have less of the duplication and, yeah,
Yeah.
right. And that in itself would provide some more of your efficiencies and cost savings, right? So, but I mean, I think you touch on some, important points, I think, throughout the conversation. So, I mean, one is that, the Canadian public needs to be engaged in this, I think, as you say, in terms of what they think is important. However, what we would hear, at least through the media, right, that the things that they care most about is how long they waited in an ER for services, right? How 6 million Canadians or more don't have access to primary care or don't have
Yes.
a family physician. Um, you know, but you're saying that, so on the one hand, that's what's being reported as what we as Canadians think is most important. But what I'm hearing you say as well is that that is not the extent of the issue here at all.
No.
Um, so, what are the things that we should be talking about in terms of that? What are the real barriers, I guess, that are standing in our way to accessing timely or appropriate care or the outcomes that we would seek?
Yeah, our systems are quite discombobulated. Like we have a lot of silos in healthcare where the hospitals, I mean, I lived this I remember very well, going through my residency in Montreal that, as long as you weren't in my emergency room and as long as I could discharge you to somewhere else, I was happy because my only perspective was the hospital.
Mm-hmm.
And we still have a lot of that in our system, right? I was meeting with a group of mental health workers yesterday who were saying they feel like, they often get calls and you can see that other parts of the system are trying to move patients to them so they can free up beds where they are, and they may not be moving the right patients, et cetera. So that kind of systems approach where we're all in it together and there's no one component that's more important than the other, I think is an important lens to bring to any conversations. If I think of that disconnection, it leads to a lot of wasted opportunity, and it all speaks to not being patient-centered, right? It's our system,
Yeah.
despite all the talk about, person-centered care or patient-centered care, I still believe our system is very system-centered. And so, those are the kinds of things we need to bring up. And then we also need to have the conversation about if we're going to allow more or different privatization into our system, what does that look like?
Mm-hmm.
One of the things I was very used to in Ontario was the privatization of hospital labs. So is every hospital need to have a lab, or can you send your specimens out to a much larger lab somewhere else? Can you save money doing that? And can you provide more service? If the answer is yes, then why wouldn't we look at that?
Mm-hmm.
Right. And again, it gets back to that thing we said earlier about sort of duplication. Do you have conversations around what do we have where, and do we invest heavily in air transport
Mm-hmm.
so that people can be brought to a center of excellence to get the care that they need? I mean, one of the biggest challenges Canada faces is our geography.
Yeah.
I mean, we our healthcare is always going to be expensive because of just the distances and things like that. But what are we going to offer in Yukon? What are we going to send people away for? I mean, places like the Yukon, the North, they figured this out to a large degree because they have absolutely no choice except to figure it out,
Yeah.
right? You're not going to get a cardiac cath in a small community in Nunavut. You're going to have to be airlifted. Whereas when you get into the more populous provinces as you go down south, well, we should be having those conversations around who's doing what. And maybe we invest in a lot of, air transport, et cetera, to be able to move people around and not just think of provincial boundaries all the time.
Yeah, I think it's an important idea. And, is it, what is most important to Canadians? Is it the best quality of healthcare that you could get for a treatment of whatever kind that might be, or is it having that treatment closest to you? Right. So,
Yeah, and it also depends on the time, right?
yeah.
I could easily say, for me right now, the most important thing is for me to get access for good quality primary care so I can get same day appointments when I need it, that when I call them, they answer the phone. I can see a physio if I need it. And that's all well and good until I get diagnosed with lung cancer.
Mm-hmm.
And then suddenly it's not about primary care anymore. Now it's the same thing over again, but for cancer care.
Yeah.
Right. And so that's why it's so hard that when we say we're going to focus in these areas, it's not like the other areas don't matter. They do. They may matter for a smaller percentage of people. Not everybody gets cancer, but everybody needs access to primary care. But that's the challenge. And I think that we've treated a complex adaptive system as a relatively complicated one. And we just think it's just about logistics. It's just about this and that, and we can make it better. But the reality is Canadian healthcare is like a living organism.
Mm-hmm.
Um, it's so much more complex. Healthcare is considered the most complex system humans have ever created. And that, quick fixes don't work. And so I guess that's why I'm getting at, we really have to get into the thick of it. There's no way around it. There are no quick fixes, and we need to debate it, because it is through that debate that you start to find ways forward that you and I aren't going to figure out on this podcast today, right? Because you need a lot of voices from a lot of different perspectives to get to a new future.
Yeah. So, I mean, I think it's another interesting sort of part of that conversation, Michael. So, I mean, so I guess, do we engage the general public in the discourse that we're having right now and ask them those hard questions? Um, is that part of what you're suggesting? And is part of the challenge in that, I guess, is that perhaps the average Canadian, and I don't want to talk down to anybody in this part, but because the system is so fundamentally complex and complicated as you've described,
Yeah.
they don't understand, right, some of what's involved in some of these things. So those kinds of
Yeah.
conversations, we as a general citizenry don't have those conversations because of that complexity. But
Yeah. I mean, I think it's a really good point. And I do think, though, you can set parameters around it. I'm reminded of a story, and I wish I remembered where this was. It was a Canadian hospital administrator. I think it was in Ontario. It was about 10, 15 years ago,
mm-hmm,
who had to go through significant budget cuts, and who, instead of doing them on his own with his senior team, he put it out to the small community that the hospital served and said, "We have this much money. This is what things cost. What do you want us to be able to provide?"
mm-hmm,
And you might think, well, how are people possibly going to make that decision? But I could turn it around and say, how could I possibly make that decision for Islanders? I
yeah,
don't know what matters most to them. I mean, I'm going to have an informed opinion, but mine isn't the only opinion. And so, once you get all of that coming forward, it's not a guarantee that we're going to do everything that people are asking for, but at least we've heard them and we can explain why we're not doing it.
mm-hmm,
One of the things that's come up here has been people should have access to chemotherapy very close to their home community. And I've argued we can't do that. Chemotherapy is very dangerous. That could be very unsafe. We'd have to have specially trained staff everywhere. I don't know how we're going to hire them. That's not probably something we want to get into. But I can give that explanation as to why, right? I can give the explanation as to why you're not going to get open heart surgery in Prince Edward Island. We don't have the population to support it. We'd have to hire a minimum of 3 cardiac surgeons. Most of their day, they'd be hanging out on the deck looking at the ocean because they wouldn't have enough business, right? So I can explain that back. But I think that, I think Canadians, we need to trust the fact that they have a reasonable understanding of what their basic needs are in terms of healthcare.
mm-hmm.
And we can provide expert advice to that at the same time. But I think it'll get us to a better place than where we are today,
Mm-hmm.
where I think it's people like me that make decisions based on my own opinion and the opinion of a few other people. I would far rather have, widespread discussion around what we should be doing. I mean, imagine if a province took that on, but that would be pretty cool.
Yeah, I think so. I mean, just because it's complicated and complex doesn't mean, and it would be hard to do, doesn't mean we shouldn't do it.
Yeah.
And I do think, I think, as you say, it would be pretty cool. I mean, because we'd be engaging, right, everyone in this conversation.
Yeah.
Um, and just because certain conversations with our children are difficult doesn't mean we don't have them. So
Yeah. I mean, I think back to my consulting days, right? One of our guiding principles was nothing about me without me. Don't make decisions that affect me without talking to me first.
yeah,
But we do that in healthcare constantly.
yeah, yeah, and we're not, a paternalistic group of people with children, right, in the space. We're all equals and all rely on that same system. So we should
Yeah.
talk about it. I would agree. So, you know, maybe this next question is taking us back in the conversation, but maybe you can synthesize a little bit more of this around. So, one of the other sort of prevailing narratives, I guess, that we've been hearing a lot about through the pandemic, a lot especially, but certainly before as well, is the questions about the numbers of doctors and nurses that we have, right? And so many of the conversations about that we need more of these professionals, and I'm not saying we don't, but that seems to be sort of the alpha and the omega of the conversation when it comes to our health workforce. So.
Yeah.
Um, get you to comment on that and whether that is that the story, or is there more to it?
Yeah, I mean, I would say that's certainly part of the story. That's an area where I think governments tend to simplify it, right? And they talk about doctors and nurses. I would expand it to say we need healthcare workers of all stripes, right? I mean, and again, I kind of live it here, right? Where we'll finally recruit a doctor, but we don't have any OR time for them because we don't have enough operating rooms. We don't have enough staff to staff the operating room. So great, you've recruited a doctor and they can't do anything, right?
Mm-hmm.
So it really is, in my mind, it is about broadening recruitment in general, and recognizing that there's lots of professions out there that aren't the top two that governments talk about that have just as critical roles. And again, that's something here on the island that I'm particularly sensitive to. Is the narrative here has often been about doctors and nurses, and really excluding a lot of other people who have just as important roles. I think the other thing is that we have a lot of barriers that have been imposed over the years that are really designed to keep people out.
Mm-hmm.
And you can. And again, this is not me pointing fingers. This is saying this is a system that was designed for another time. And so, for example, we've got lots of Canadians. So in other words, by definition, they're eligible to work here. They're Canadian citizens who are training in medicine overseas. When I did work in Ireland, I couldn't believe when you walk in downtown Dublin, how many Canadians you meet, and most of them are medical students. And they're either at Trinity or at the Royal College of Surgeons of Ireland. Large percentage of their class are Canadians who weren't able to get into Canadian schools. And it's not like these are bad doctors, because I've worked with a number of them who are as good or better than any Canadian trained doctor I've ever worked with. But we treat them as foreign medical grads. So it's quite hard for them to get back to Canada when they've trained overseas. Where do they go? The United States. We have a fantastic pipeline to give the United States Canadians who have trained in excellent universities overseas.
Mm-hmm.
That's not good. That just seems like such a wasted opportunity. And where does that come from? Well, I mean, it's different groups that have wanted to control the number of doctors we have in the country. If I use doctors as the example, right? Governments love to control the number of doctors. When I graduated from McGill in 1992, I got a letter from the Quebec government saying, congratulations, don't think of practicing here. And at that time, it was when the Ray government had stopped doctors getting new billing numbers in Ontario. So I'm from Ontario. I go to Quebec. Quebec doesn't want me, and Ontario doesn't want me. So governments are involved in that game because doctors are expensive. We order tests. In a very cynical way, not having a family doctor in the short term saves money.
Mm-hmm.
In the long term, it costs you more because people get sicker and you're not preventing things. But short term, it might save you money. So governments are involved in it. Medical societies are involved in it, right? We have our captive audience, and we want to keep that captive audience. Our Canadian colleges and universities don't want to have competition with their graduates, et cetera. We've got a system that really wants to keep people out. And a lot of that was designed at a time when we were not nearly so short of healthcare workers, and you could see some logic in it, right? We don't want to have like a doctor on every street corner. One, we can't afford it, and two, they'll have nothing to do. But we're not there anymore. Now it's completely different, and yet we have to try to, how do we dismantle enough of that system to ensure that people can get here much quicker, but also, don't throw quality out the window. Right? Because not all medical schools are created equal. But the ones that our Canadians tend to go to, they're good schools.
Mm-hmm.
Right? And so there's stuff that should be done there, and we are starting to do that. And to me, focusing on Canadians that have trained overseas takes away the the guilt that I feel going into less developed countries and pillaging their healthcare workers.
Yeah, for sure.
Because I have a hard time with that one.
Yeah, especially
So,
today.
so we can make it better internally by offering more positions and making it easier and incentivizing the kind of behaviors we want. But we can also make it easier by breaking down some of those barriers and letting people come in. And I think we'll get there. I mean, healthcare human resources tends to be very cyclical, right? It goes up and down. When I graduated medical school, nobody wanted doctors. It's like 3 years later, everybody wanted doctors. And we will improve. I have no doubt this will get better. The question is do we tweak it? Do we slap Band-Aids on it? Or do we come up with a brand new healthcare system? And I'm arguing it's got to be the latter, because if we just put Band-Aids, we'll be in the same place a year or two from now, and we'll be asking for even more money. And honest to God, like, how much money do you want to throw at this before you face the hard facts? We have to tweak it. Like,
Yeah,
really.
I mean, there is I think as you're describing there too, I mean, what comes to mind is that there's definitely a labor market discussion that needs to happen, right? I mean, we as Canadians wouldn't control the influx of how many plumbers,
No.
right, cooks, right,
And,
lawyers or whatever else, right, that make up our economy, right? So, right, it is a supply and demand. It is excel and be paid at, or don't, and find another career. But in healthcare, we have a controls, I guess, on that labor market.
yes.
And so, is that, I'm leading you a bit, but I mean, is that the problem, or in terms of some of this stuff with respect to
It's
our workforce?
Yeah, it certainly is part of it, right? I sort of cynically say it's a little bit like Soviet central planning, right? And I mean, when we do that, it doesn't necessarily, it doesn't allow us to be nimble and adjust as we go. And so whenever you're trying to, I would advocate for a bit more of a free market approach.
Mm-hmm.
Maybe not fully free market, because it costs a fortune to train a doctor. And doctors do, I mean, we are paying for the doctors, so the doctors cost a lot of money. But but we do have a little bit of that right now. So, for example, it's not a great time to be an orthopedic surgeon in Canada, because we have more orthopedic surgeons than we have hospital positions.
Mm-hmm.
So that's a group where we probably train too many of them. Family doctors, it's exactly the opposite. So I do think some element of free market in there does make very good sense. And at the same time, now that we're talking about breaking down the barriers between provinces, so that me having an Ontario license would make it much easier for me to practice in any other Canadian province, because right now I'd have to go apply and do all the other stuff, and it would be a big production. If we break down that barrier, then if we are overserved with doctors in Prince Edward Island, then I have nothing to do, which, believe me, would be a dream of mine if we ever got to be overserved with doctors. Don't think it'll happen in my lifetime, but if it ever did, then I can say, you know what, there's no jobs for me here. I'm going to move out west, or I'm going to move here, or I'm going to move there, just like we do in every other industry.
Mm-hmm.
Right? If you're working in downtown Toronto and you get laid off, you look for a job elsewhere.
Yeah.
And so I think it'll be an interesting experiment as we break down those interprovincial boundaries, what that's going to do. But I do think it's an important thing to try and see where it gets us.
So another part of the discussion, I guess, so we're talking about, people and the development of those people, right? But is learning and development as a more part and parcel of that, right? So, and certainly given my own role in training and development, I'd be remiss if I didn't take the conversation there. So, what role, or what conversation do we need to have around professional development, I guess, as part of our discussions around the system transformation side of things, and as we move out of this crisis?
Yeah, I mean, that's become really obvious in the last year or so, where we basically went through three years where people just went into survival mode.
Mm-hmm.
And, like there were no conferences, there was no this, there was no that. You were just trying to, focus on keeping things together. I mean, even for me with my, with the Royal College of Physicians and Surgeons of Canada, we were totally appropriately given a break on those professional development credits that we have to get every year, because just I don't have time for this. I have to focus on the issue. And you really feel it, like we've moved, like we healthcare needs to be a learning organization. We need to be learning and adapting and assessing what we're doing and changing what we do all the time. And when you take away the ability to have access to professional development and learning new ideas and rubbing shoulders from others, you can almost feel us, like you start to stagnate very, very quickly.
Mm-hmm.
And so I do think that there's a huge role for that. I think, one good thing the pandemic gave us is I think there's a lot more virtual opportunities than there would have been pre-pandemic. I personally am not a fan of virtual teaching. I still do it, but on the one hand, I like the classroom better because I can actually read your body language and we can really have a conversation. On the other hand, I can reach a lot more people virtually.
Mm-hmm.
And so there's a trade-off. So let's figure out the balance of in-person, virtual, and let's move forward with a lot more of that. Again, do I need professional development that's unique to PEI? I need some of it, but there's a whole whack that I should be tuning into somebody else, because I also want to get broader, more diverse opinions than just here on the island. So does every Canadian system have to have its own big education, professional development thing, or could we start collaborating? And it's neat coming here because there's always been a history of collaboration with the Atlantic provinces, and it fits very well with my kind of mindset, because we talk about that all the time here. How do we pull our resources together, because we're smaller provinces population-wise, right? All of Atlantic Canada is 4 million people. So how do we do that so we can, get the biggest bang for our buck? How do we get diverse opinions? So I think the pandemic has helped us look in that direction a bit more, which I think is very positive.
Yeah, I agree. I mean, I think that there's a lot. I mean, innovation in and of itself, I guess, is what I'm thinking, right? Requires collaboration and requires more people to sort of share in those ideas. So, right, the stronger we make our silos, right, the more we exclude those other thoughts and opinions, I guess, from engaging in that. So, I think to your point around, the pandemic has given us a greater openness to virtual everything, including learning, that it's another opportunity for us, I guess, to take the best of the best from others across the country or internationally even, right, to help, I guess, in that transformation.
Yeah, the best of the best and for less money.
Yeah.
Like that's one of those rare win-wins that you hear about, right?
Yeah, for sure. And while it may not be your personal preference in terms of how you would like to learn or to teach, even, I think, different demographics obviously are coming into the system where those values are different. So.
Yeah, absolutely.
So related to this is, I guess, the current state of our of leadership in healthcare. We've obviously talked a lot in our conversation here today, and certainly around us, around clinicians, and the clinical part of healthcare. But there is that leadership part in your role. Another great example. So on the one hand, we have this thing that has been booted around probably way too much, this great resignation, which is, it happened. As 2 generations of leaders have been exiting the system sort of en masse. So, how does the system respond to that or pivot from that as we move forward?
I've met a lot of, I'll talk mostly about physicians because in my previous roles, that's mostly who I was dealing with. But I've met a lot of physicians who are going to be superb leaders in the future. And I think that they have the added advantage of having gone through a pandemic.
Mm-hmm.
And so I do think we'll take a bit of a dip for a while, but I also think getting an infusion of a lot of new ideas and people who have experienced different things, who grew up with virtual technology, who grew up with a lot of the stuff that we use now, that's all going to be good. That's all going to be a really nice addition to the system. I really felt this when I was at UHN back in 2003, the difference in leadership thinking about hospital infections and pandemics and scary stuff like SARS. I used to joke that prior to SARS, as a physician working in infection control, which is basically preventing the spread of infections in hospitals, I used to say we had the same status as a shrub on the front lawn of the hospital. Like nobody gave a damn about infection control. Then we go through SARS, and suddenly this whole field that people like me have been yammering about, for like over 100 years about how important it is to do this, suddenly people experienced it for themselves. They had the social proof of what we were talking about. Because
Mm-hmm.
other than that, without the social proof, you're too busy looking at other stuff all the time,
Yeah.
right? It's like a similar story, doctors may not be the best at relating to patients until they become a patient.
Yeah.
And then suddenly it's like, oh, that's what you're talking about. Now I get it. So we have a bunch of leaders, especially, and really only in Ontario, that experienced SARS, that made them much more open to patient safety. And when I would go and off and do consulting in other parts of the country, I felt a bit like I went back in time because they didn't go through SARS the way we did. And so now you got a whole generation of people that are growing up that went through a pandemic. I don't think there's going to be a leader for the next 50 years who's going to say, why are we planning for a pandemic? Like, this is stupid. These never happen, right? And, I don't think you'll have to talk to a lot of new leaders about having some resiliency in our system because they all went through, worried about having to make triage decisions on whether you get a ventilator or not.
Mm-hmm.
So I think getting an infusion of new leaders who have gone through these experiences is only going to make us stronger. And I do feel the great resignation. I mean, I'm in my late 50s, and this hasn't been a particularly fun pandemic for me either, right? And I kind of get it. I get why people might say enough, but I also think there are great people out there who can move into these roles. And I think that's where that professional development comes in. How do we train the next generation of leaders so that they're ready to go? Because I would argue the earlier generation of leaders, they kind of winged it. Like most of them didn't have leadership development opportunities. There weren't any podcasts. They weren't,
Yeah.
leadership in healthcare is a relatively new phenomenon, as something that you would actively train in. And so I think we'll be better for it down the road. So it'll be a bit of a dip, but I think we'll get through that piece.
Yeah. Well, I think you raised some really important points. I mean, one is that I guess to some degree leadership isn't learned in a classroom, and we've created the best incubator for the
Yeah.
development of those skills through a pandemic, which is an experience that everybody globally has shared in. And yeah. I mean, it is sort of like that massive forest fire that rushes through and takes all the old wood out, which I'm not
Yes.
suggesting all these
No,
people
but you're right.
retiring, right?
There is a lot of stagnation. I mean, our healthcare system is stuck in the rigidity trap. This is the way we've always done it. And the way you get into a new world is you bring in a bunch of new people with very different opinions from yours.
Mm-hmm.
And, so I think that aiming towards that new generation of leaders is absolutely critical for us. And I don't think they need to be like me. I don't think they need to be like the previous generation of leaders. They're going to find their own way, but I think we'll have prepared them much better for it.
Yeah. So on that point, that is, I guess, that's sort of the follow up to the question. So then, of those new leaders that aren't going to be like you, that are going to be bringing in different skills, potentially different ideas, and be more resilient, likely, I think, as you've said. What are future thinking? I mean, what are the right skills that they're going to bring, or the abilities that the system's going to need to continue to go through the change that you've been describing through most of this podcast?
Yeah. It really requires, if you look at the LEADS framework for, judging leaders
Mm-hmm.
in Canadian healthcare, for example, I mean, the ability to have insight into your own strengths and weaknesses, to really cherish diversity. I mean, there's an old rule in human resources, right? That people tend to hire people that are just like them.
Mm-hmm.
And so we need to really increase diversity in all its forms, to get a much richer debate going. And our new leaders need to understand they don't have all the answers, and nobody expects them to have all the answers, and that they're going to go back to their team and discuss these issues, and we're going to figure it out as we go ahead, right? I think it requires a much more collaborative, engaging, listening leader than maybe what, certainly in medicine, I think we still have the idea that, we're the boss and we know what's best and we're going to tell you what to do. I think that's rapidly changing now. And that change is going to be really good for the healthcare system. Because I'm the first one to admit, I don't pretend to know how to fix our system. All the talk we've been having today has really been about what are the conditions you would set up to get us to that point.
Yeah.
Right. But I think it's naive for me to think, oh yeah, private standalone surgical clinics, that's going to solve our problems. That's going to inevitably have multiple ripple effects throughout the system. And it might be a great idea. It might not. I don't know. We should study it. We should, but good example of politics in healthcare, right? You'll have someone stand up and say bad. Well, you haven't even studied it yet. And I think there's good, it may be bad, it may not be bad, but I think you'll get a group of leaders that are much better at that going forward.
Lots to think about there. So I mean, I know we've been yammering away for quite a while here, Michael, and I'm respectful of your time and very grateful for you spending it with us. But so, I mean, with all that, what you have said and shared with us so far here today, and coming back to that burning question in my intro, what needs to happen next to build that healthcare system that meets the needs of our Canadians?
Yeah. Yeah. I mean, I think in an odd, perhaps paradoxical way, part of me is happy that the provinces didn't get everything they asked for, because I think that would have given enough to paper this over for another few years.
Mm-hmm.
So I think it does put a little bit of a gun to the province's head to say, like, okay, you actually still have to do the hard work. I think the immediate next steps are shoring up our system to allow it to continue to function while we figure these things out, but really start with that engagement and start talking about what should our system be going into the future. And I personally like the idea of talking about like a Canadian healthcare 2.0.
Mm-hmm.
That we're not just going to slap a new coat of paint on this. We're actually going to challenge assumptions that were made over a half a century ago in a very different time. Let's open it all up. Let's challenge it. Let's learn from other countries, and let's try different things and be really open to safe experimentation,
Mm-hmm.
right? Because it's always hard, also a bit hard to experiment in healthcare because you don't want to harm anybody in the process. So you've got to figure out how do you try new things, but in a not in a risk to patients or patient safety. You might risk money, but you're not going to risk people.
Sure.
And try to figure that out. But those are honestly the immediate next steps. Shore up our system so we can keep the lights on. I sort of joke that, the vision statement of Canadian healthcare should be keeping the lights on for one more day, right? We want to move away from that, and we want to move into, keeping the lights on and improving for the foreseeable future. That's where we want to get to. And so it's immediately those conversations. And I think the public has an incredibly important role in those conversations. And there's no way around it except through it. We have to go through it.
Yeah, well, I mean, some of the metaphors and imagery you've been using, right? I mean, about wallpaper, paint, and right, lights and things, right? I mean, we're not talking about just flip this house, right, for the next buyer, right, or
Right.
next generation, right?
That's
I mean,
right.
you're talking about a renovation, taking walls down or
Yeah.
more, right? So
Yeah, no, we need to take it down to studs, shore up the foundation. We need to weatherproof our system. We need to do all sorts of it's I'm not saying it's a new build
hmm
because there's a lot of fundamentals of our system that every Canadian will agree with. Like I said, if I get sick in Ontario, I expect you to care for me. We agree that emerge care, primary care is access to good mental health care. All those things are going to be really critical going forward. So we're not talking about bulldozing it, but we're talking about where needed, taking it down to the studs and really rebuilding it in a way that makes sense for Canadians.
Yeah, and I think in that, right, I think some of the other, I guess, themes and messages that I've heard throughout even the different, very different parts of our conversation today, they focus on interjurisdictional collaboration, right, and
Yeah,
sharing, right. Even in your discussions around leadership, it's about collaboration, right. So, right, we are not going to do this in silos or in provinces or within our own leadership walls, right. It is going to be sharing of resources, whether that be knowledge, whether that be uh, physical infrastructure or skills, right? It is going to be, I guess, harnessing all of what Canada has, right, to be able to do this together.
yeah, absolutely. I mean, we're never going to open up the Canadian Constitution to change who's responsible for healthcare, but that doesn't stop us from collaborating with each other.
hmm Well, I appreciate you sharing that vision with us here today, Michael. I hope that it inspires, many others to engage in this work going forward. I think, as you've said, you've provided people with the conditions for what needs to happen. That everybody needs to play a part in terms of fashioning those conditions, so that we collectively can engage in these hard conversations and choices, and build that healthcare system or systems of the future that is truly accountable and serves all Canadians.
Yeah, let's hope we get there. We kind of have to. We don't really have much of a choice in the matter.
No, I agreed very much. So thank you very much again for sharing us with your time today, and look forward to talking to you again in the future.
Great. Thanks so much for having me, Dale.
You've been listening to the HQ, and I'm Dale Sherback, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.